Okay, thank you. Thank you to the organizers for giving me the opportunity and for us to discuss on this rather important topic. I'll be talking about preventing progression in childhood myopia, and everything that I'm going to speak on is related to or is actually concised in this excellent consensus guidelines that were released by AIOS. So if by chance you wish to follow up on what has been talked about, you can check this up. This is, I think, available on the AIOS website also. So thank you again. The most important question that we need to ask is why to intervene? And over the last decade or now, I think this question has become a wee bit redundant, especially in 2016 when this paper from Brian Holden came, which has predicted that 50% of the world's population is going to be myopic. When we actually analyzed the data set in that paper, we realized that India had been given a miss because according to them, there was not enough data of good, well done surveys or studies from India, and therefore really the Indian 1/6 or more now of the population was kind of aggregated based on data available from Nepal, Bangladesh and nearby states. We actually did a systemic review and meta-analysis of all the data available in India and over the last 4 decades, and based on that we came to a crude prevalence of 7.5%. And the most startling thing we actually found was, and unfortunately this data is pre-COVID, so we don't know the impact of COVID, while we all agree that probably it's going to accelerate the progression of myopia. The other important thing that we realized was the significant increase in the last decade in rural children. So while we used to think that rural areas are rather safe, but just in the last decade it has apparently increased from 4.6 to 6.8 based on the data sets that we have in the various parts of India. So when would we intervene? Our decision should be based on the risk factor identification. So each child falls into a basic risk factor group, which is dependent upon the baseline refractive error, the magnitude of myopia that he is diagnosed with the moment he presents to us, the age of onset of the refractive error. So the younger the child is, the more years he has for progressive myopia, and he's going to land up at a higher level of myopia by the time he levels off, and therefore your decision to intervene and the rate at which you are, how aggressive you are, is going to be accordingly tapered. Genetics or the parental refractive error, the family influence, both parents, if they are myopic, have a 3 times risk of progressive myopia in a child, and of course the visual environmental considerations. The other most important thing we feel is that you must document myopic progression of at least 0.5 diopters a year. You can not necessarily have to follow up the patient for a year. You may keep a record of, evaluate the record of the previous glasses, the power of glasses. The only downside of that is that sometimes, unfortunately, many ophthalmologists undercorrect the first time a patient is prescribed glasses, which there is no evidence to say that undercorrecting refractive error will at any time reduce the rate of progression or in any way is beneficial to the child. So you identify a child of myopia, give optimal glasses. Do not undercorrect, of course, never overcorrect a myope, but definitely at the moment there is no evidence to say that you should undercorrect. That way you'll be able to know what is the rate of progression of myopia and accordingly decide your interventions. Risk factors, the most important are the refractive errors and including the fact of pre-myopes. There is now a defined category called pre-myopia, which essentially means that their refractive error is a lower hyperopia than the age-matched normals. And for about a 6 or 7-year-old child, it's about 0.75 diopters. So less hyperopia or myopic obviously becomes a myope, less hyperopia pre-myopic child. Younger age group I talked about, parental history, progressives, females for not so very clear reasons are at a higher risk for progression, and of course ethnicity, while Indians don't come into it, but East Asians definitely, so maybe we should be concerned about our northeastern regions. The other modifiable risk factors or environmental risk factors are the visual environment. Children who become myope are tending to spend less time outdoors, unfortunately accelerated by COVID. A lot of near work association is now being proved, reading at very close distances and continuous periods of time. The other important thing being highlighted now is the anomalies in binocular vision and accommodative lag. So esophorias, accommodative lag at near, and reduced accommodative facility. And of course, not so clear inconsistent association with other attributes. Preventing the onset, identify the pre-myope child. We talked about low hyperopia, a genetic history, spends less time outdoors, increased near activity, has some form of binocular vision disorders. At the moment, at least in India, there is no evidence that you should pharmacologically or optically intervene. However, you need to educate the parents and the child. Risk factor modulation, try and reduce the near work, give breaks, encourage outdoor activity. So these are the interventions we would recommend for a pre-myope. It's important to discuss this with the child and the parents, particularly how to reduce the environmental risk factor the child is in. The moment you identify or you consider myopia or consider myopia interventions, do an age-appropriate cycloplegic refraction. You can use an AR also. Objective retinoscopy, at least at the baseline, is useful. Prescribed glasses, do not undercorrect, as I talked about. Document the glasses because it will help us to document the rate of progression of the child. Now, axial length measurements, irrespective of the way you are measuring, whether it's ultrasound or optical, most of us have optical biometers with us, so an optical biometer would be very, very useful, because finally axial length is what you need to prevent progression, and that is where your intervention should be. Binocular vision, ocular surface health, if you're looking at intervening by ortho-K or soft contact lenses, pupillometry or the size of the pupil, because atropine may make that small difference, and of course fundus if there is myopia. You have a lot of optical interventions. There is no evidence that single vision glasses make a difference, but anyway, that is something that all children deserve to have. We have now what are called peripheral ad lenses, which reduce the peripheral hyperopic defocus. They are optimally corrected for the central foveal area, but peripherally they are bringing about a myopic defocus as compared to a peripheral hyperopic defocus, which is thought to be the cause for progressive myopia in these children. The next important thing is, of course, to look for accommodative lag, because these children would require an ad or a near vision glass along with the distance correction. So that's another important aspect that you need to identify and measure. There is evidence now that bifocal prismatic ad lenses can significantly reduce progressive myopia versus single vision lenses in children who have accommodative lags. Soft multifocal lenses were perhaps the first thing actually that got FDA approval for management of myopia, and Cooper Vision MeSight were the first ones, no financial interest. They have been found to be definitely helpful. Ortho-K, again, unfortunately, contact lenses are not very popular in India, but Ortho-K have been shown to reduce progression by almost 45 to 50%, besides, of course, keeping the child spectacle free during the daytime. We are all aware of the pharmacological interventions. Atropine is the most common, most popular. There is now hard evidence that 0.01 reduces the progression. There is now growing evidence that 0.05 may be a better cutoff based on the effect of preventing myopia progression and the side effects. But of course, there is an ongoing study, multicentric trial in India on 0.05, so we hope we'll get better data and be able to decide which percentage is better for Indian children. Finally, deciding options, very small children, make sure it's progressive. It may just be part of their congenital myopia or part of ROP or a preterm birth. Low myopes may be part of emetropization and may not require intervention. 6 to 11 years is our key area of intervention, because after 12 to 13 years, although again this knowledge is changing, we expect their progression to actually level off on their own. So again, the other rest of the things I've talked about, ocular surface, binocular status, and of course identify genetic factors. Atropine, treat for at least 2 years, then taper, do not sudden stop. Contact lenses, look for financial aspect. Of course, the parents and the child should agree. Both Ortho-K and soft contact lenses need monitoring even after you've stopped, because there has been a rebound effect or the wearing out of the preventive effect of optical interventions. And of course, for children who are very rapid progressors or continue to show progression in one form or the other, there is evidence that combination therapy may be much better. You assess outcomes at least 6 months, because before that you cannot know whether your impact is effective or not, and based on that you decide whether you want to switch or you want to augment interventions. But sometimes it may take up to a year, so it's not a very short-term intervention that you can decide on. Treatment may be stopped or switched depending upon your rate of progression, tolerance, compliance, and of course cost features. So this is just finally a chart showing the various impact of the various interventions that we have. You can see everything works, but the most important thing is all children, all parents need to be informed about the impact of environmental modification, outdoor activity. Of course, soft contact lenses, ortho K work, not so popular in India, and of course, atropine, low dose atropine drops are definitely effective. Thank you very much for the opportunity.
Thank you, Dr. Rohit. I'd just like to, sorry.
I'm sorry?
How will you taper after 2 years for rebound?
So if you are having once a day, usually you are giving the therapy once a day at night. You can go to alternate day for a month or 2 months. Then you move to weekend. Then you need to go to once a week. And after that, you can stop and then follow up after 3 months. So you have a 6-month period in which you can actually see is the child rebounding, is the rate now picked up again or not. So you remeasure for the change of refractive error.
Is Dr. Deepti there? No. Dr. Rohit?
Dr. Amit has come, so maybe he can.
Yeah, Dr. Amit.
Yeah.
Dr. Amit, you can take your, in the meantime, Dr. Rohit, just small, yeah, sure, go ahead. Yeah, that's what I was about to.
So unfortunately, there is no hard evidence. There is a group which says that if there is evidence of peripheral hyperopic defocus, they would be the best. But evidence has shown that there are only 30% or 40% children who actually have proven peripheral hyperopic defocus, as compared to results of studies on these lenses showing 70 to 80% effectivity in children. So I would say that currently there is no hard evidence to choose either or. Of course, if there is sometimes parents are not willing for pharmacological therapy, or there is children who start on topical drops, have glare, have near vision problems. In those conditions, it's definitely beneficial. Parents who are unwilling to start a drop. Otherwise, really, there is no hard and fast rule to decide whether you want to take optical. Opticals are very expensive. They are anywhere between 12 to 16,000 rupees a pair of glasses. And you know that no child is going to just keep one pair of glass. And of course, within a year, the change of refractive error may occur. So that is why cost is a major factor. But otherwise, at the moment, there's nothing very clear to differentiate. You have contraindications for not using one form or the other, but definitely for contact lenses, but not so much for optical versus. And now they're very easily available, so availability is also not a cost.
Ruth, there have not been much studies of using combination therapies, as in pharmacological plus the spectacles, or pharmacological plus the orthochirurgy, both at the same
True,
time.
actually, because we are still establishing the place of individual. But yeah, with contact lenses and atropine, there are a couple of studies which have shown that both of them, because they probably work by different routes, have an additive effect. But of course, you not start both in the same go in the first time in a patient. You want to actually evaluate the impact of either on the rate of progression, and then probably move on to augment.